Thank you very much for this question. For myelofibrosis, the disease can be very heterogeneous. So we have patients who can live very long without stem cell transplantation, but if patient has several risk factors and the survival is short, then we would recommend allogeneic stem cell transplantation. So allogeneic stem cell transplantation is currently the only curative treatment approach for these patients. And the treatment is many times, it's not only the chemotherapy and the stem cells, it's also the post-transplant intervention and the pre-treatment of the patient to prepare the patient properly for the stem cell transplantation, to reduce, for instance, the spleen size, which is one of the options. And the other options is to use more reduced intensity conditioning, which is not so toxic for the patient and can be done also for older patients or elderly patients. And very important, what we learned in the last year is the so-called post-transplant intervention, because in the transplant, the patient are receiving a new hematopoietic system, and then in the first years, or let's say the 6 months after transplantation, then the new immune system is working and is trying to kill the myelofibrosis cells, but is also causing graft versus host disease. So therefore, it's up to the physician to monitor after transplantation very carefully to harness this graft versus myelofibrosis effect in order to cure this patient and to avoid relapse and so-called non-relapse mortality. Yeah, so in myelofibrosis, the intensity of the conditioning regimen has no major impact in outcome. So that means if you want to reduce the risk of relapse, it's not the intensity of the conditioning. So we would recommend to go in all these patients with reduced intensity. And then regarding reduce the risk of relapse, you should do something post-transplantation. If patient has engrafted, you can monitor this patient very closely with molecular markers, and you can check, is there still residual disease? And if there still is residual disease, which you can monitor with these markers, then you can, for instance, reduce immunosuppression to increase the T cells to kill the residual myelofibrosis cells. So for relapse prevention, post-transplant is more important than intensity of the conditioning regimen. So what we learned in the last years is that the transplant is not only conditioning regimen and then the stem cells infusion, it's only the preparation to reduce the spleen size, but also do some post-transplant. And the most important what we learned is to monitor this patient after transplantation, whether there is still residual disease. So they can have a normal blood count, they look good, the bone marrow is good, but if you look molecular markers where you can detect minimal residual disease, this is important because this can be treated then by increasing the donor T cells, either by reducing immunosuppression or later by giving donor lymphocyte infusion to kill also the last myelofibrosis cells before they can relapse.